quiz with Dr. Ajay Bahal. We'll have the discussion by Dr. Murali.
Since 2 years. One episode of syncope 6 months ago. The breathlessness was gradual in onset and progressive. Initially, while walking up a hill or 2 flights of stairs, which then later progressed to breathlessness on during household activities, like taking a bath and happened for the last 2 weeks. And was also associated exertional pain. It was poorly recognized, constricting in nature. And this complaint has also been progressing over the last 2 years in the same manner.
Malav, can I interrupt? Can you speak louder and then I'll request everyone else to mute themselves because there's some background noise.
Okay, sir. Hello. Can you hear me now,
Malav,
sir?
can you just speak
Please,
a bit loud so that everybody else can hear?
Yes, sir. So patient had breathlessness which was gradual in onset and progressive, initially while walking up a hill or 2 flights of stairs, which progressed to breathlessness or doing household activities like taking a bath and wearing his clothes over the last 2 years. There was also exertional chest pain, which was poorly localized, constricting in nature, and was associated with postprandial angina. He had one history of loss of consciousness for about 2 to 3 minutes while trying to lift a heavy tire, which was followed by a fall. There were there was bystanders was his wife. So from that we got history that there was no abnormal movements, frothing or tongue bite associated with this fall. And there were history of multiple such episodes of giddiness on prolonged exertion or while starvation. There was no history of orthopnea, paroxysmal nocturnal dyspnea, abdominal distension, or pedal edema. There was no history to suggest any breast angina, any palpitations, or limb claudication or headache. No history of any fever, joint pains, rash, recurrent fever, joint pains, rash. No history of any postictal confusion, bowel bladder incontinence. No history of any seasonal variation of symptoms or any wheezing. No history to suggest any blood loss or any hoarseness, dysphagia, cold intolerance. His past history, he had consulted with a cardiologist for his complaints 3 months ago. He says he underwent a procedure, possibly an angiography because there was a puncture through the right groin, and he was given some medicines. He had partial relief for about 2 to 3 weeks, but then again symptoms resumed. There was no history of any fever with migratory joint pains in childhood, no history of tuberculosis, diabetes, asthma, or hypertension. He is a vegetarian by diet. Appetite, bowel, bladder habits, sleep are normal. No history of any addictions. The family history was significant. The father had died suddenly at work at 40 years of age, and he had no preceding major medical or cardiac disorders known. Comes from a low socioeconomic strata, and he's the only low-learning member of the family. So I'm done with the history. So to summarize, he's a 50-year-old gentleman who was presented with exertional dyspnea, NYHA2 going to NYHA3, exertional chest pain, exertional syncope, and multiple pre-syncopal episodes with a significant family history of sudden cardiac death in the father, possible sudden cardiac death in the father, and a history of some cardiac procedure done 3 months ago. So at this point, I would like to present my differential diagnosis at the level of history. So first, looks to be of the system-wise predominantly a cardiovascular case. He has presented with symptoms suggestive of something like a stenotic lesion, possibly a dynamic LVOT obstruction. Other differentials could be stenotic valvular heart disease or coronary artery disease and heart failure, cardiomyopathy. So at this point, I would like to keep my differentials at this.
So you've kept dynamic LVOT as the first possibility. Why not a fixed aortic stenosis?
Sir, because his symptoms-wise, he has been presenting with the syncope or the pre-syncopal episodes are happening in a waxing and waning manner. So there he's having, it is, when he said there was, whenever he's starving or is lifting heavy weights, it was much more common. So that is what is helping me to go
No,
towards
but lifting heavy weights will be there in a valvular aortic stenosis
Yes.
also, a fixed aortic
Yes.
stenosis. So why have you brought in dynamic before you bring in the fixed?
Sir, because one is that the starvation, with starvation and with fasting, he has been having the syncope. So
Is that a feature of dynamic LVOTO that with starvation you get syncope?
with dehydration, you get, sir.
Yeah, okay, with dehydration. But that may be true even with fixed
Yes,
valvular aortic stenosis.
So at this point, both are same. LVOT obstruction, sir.
Does the family history help you?
Yes, sir. Of course, but family history of sudden cardiac death in a young patient, relatively young, again points towards a dynamic LVOT obstruction.
Okay. Can a valvular aortic stenosis or a valvular LVOTO be inherited?
Yes, sir. In some patients, yes, sir.
What is the inheritance?
Bicuspid aortic valve, sir, with aortic stenosis, that can be inherited, sir. But generally in children, if it is found in children, they are relatively asymptomatic till middle age, sir. They are presented in young adults.
So let us suppose the father had a valvular, a congenital heart disease, let us say a bicuspid aortic valve, right? So supposing, what is the risk of a child getting the same disease? Supposing the father or the mother have a congenital heart disease, what is the risk that the child will have a congenital heart disease?
So I believe it is an autosomal dominant inheritance.
No, it's not autosomal dominant, it's multifactorial. So what is the risk? Supposing any congenital heart, let us say you have TOF, VSD, ASD, bicuspid aortic valve, what is the risk that a child will get the disease if the mother or father have a disease? I'm talking about the multifactorial, not an autosomal dominant inherited type of one.
So definitely the risk is there.
How much? How much? Quantify it. Give a number.
About one third chance.
1/3? No, that's too high. The risk is only around 3%. What is the risk of congenital heart disease in the average population? It's around 8 per thousand. That's 0.8%, isn't it? So if the parent has a congenital heart disease, the risk of a child getting it is around 3%, 4%. It's roughly in that range, right?
Yes.
So supposing the father has got a TOF or a ASD or a VSD, will the child have the same disease or will the child have a different disease?
The risk could be more common
Any
than
congenital.
any congenital.
Yes. Except, what is the exception to this rule?
Syndromic.
Exception to the rule is a LVOTO. If the father has a LVOTO or the mother has a LVOTO, the child will have a
Child
LVOTO,
will have it.
right? So
Yes.
that is what I'm saying. A fixed obstruction you should not exclude, because
Yes.
the exception to the rule is a left ventricular outflow tract. Supposing the father has a ASD, VSD or a TOF, the child can get any congenital heart disease. But if the father has a LVOTO, then the child will also have a LVOTO, because this is relatively fixed. So you cannot exclude a fixed obstructive left-sided lesion based on the history and sudden death in the father. So,
Is the incidence of congenital heart disease same if the mother has the same problem and the father has the problem, or is it different?
So it's different.
what
Is
is
it
the difference?
different? For example, if a father has a congenital heart disease, what is the risk of a child developing a congenital heart disease? If the mother has it, is there any difference in the incidence
So the incidence is higher if the mother has it, sir.
How much? I'll make it a little more difficult for you. Let us suppose a sibling has a congenital heart disease. So an elder brother or sister has a congenital heart disease. What is the risk then? So the father has a disease, mother has the disease, and an elder sibling has the disease. What is the risk in the child?
very high, 25%.
Very high. I mean, most of the
No,
time.
no. I'm saying between the three. Supposing A has the disease, mother has the disease, or the father, or a sibling.
Highest is with the sibling. That is the mother.
No. Not true. So your baseline is 0.8%. That is in the general population. So let us suppose the mother has it, what is the risk? The father has it, what is the risk? Sibling has it, what is the risk? Give a number, approximate. I mean, it varies in different steps.
Mother would be around 8 to 10%.
Okay, I'll give you a hint. If a sibling has it, it's around 2%.
So,
Okay, so mother and father?
so father is, I think, about 3%. And mother is about
Yes.
5%.
Okay, now we are at it. Why is it important to look for a syndrome? Like you see, you look at a Holt arm, you find that it's a syndromic disease. So in a congenital heart disease, why is a general examination important?
So when you have syndromic diseases, they generally run in families.
Yes. So what does it mean? It means that
So
it's a
the
50%.
incidence, yes, so the incidence is higher amongst
It's 50%
50%.
autosomal dominant. So if you have a Holt arm, then the risk is significantly higher than if it is a random congenital. So your two differential diagnoses are obstructive, basically a fixed obstruction, that is a valvular AS, versus a
dynamic.
Dynamic. Any other? You said a coronary artery disease?
Coronary artery disease at this stage, because it's 50 years.
So what type of coronary artery disease is associated with syncopal attack?
So left main stenosis, proximal LAD, they generally present with pump failure, attacks, even arrhythmias. So that would be. So significant coronary artery disease could be one of the differentials.
Would you like to keep something on the right side of the heart? Pulmonary thromboembolism, pulmonary hypertension, angina, breathlessness.
Pulmonary hypertension, though there is no preceding event, but in 6 months history, I think severe PAH would be one possibility, but there were no clinical history suggestive of right heart failure. So, and his age again is 50 years, and no other preceding markers. So lower on the cards.
Right heart failure is not there. Signs of right heart failure.
So I'll proceed with the general examination, sir.
Okay.
So it was conscious, cooperative, well-oriented in time, place, and person. His BMI was 22 kg per meter square. Afebrile. Pulse was 90 beats per minute regular.
Malav, I think you have to speak a bit loud.
Yes, sir. Pulse was 90 beats per minute, regular, good volume, no radial, radiofemoral delay. All peripheral pulses were felt. Carotid pulse was bisference in character. Blood pressure was 114 by 70 millimeters of mercury in the right upper limb, and no significant variation in the other limbs. JVP was not raised. Abdominal jugular reflux was negative. There was no pallor, icterus clubbing, cyanosis, lymphadenopathy. No signs, peripheral signs of aortic regurgitation of infective endocarditis. Skull and spine was normal. In the cardiovascular examination on inspection, chest was bilaterally symmetrical. No precordial bulge. Apical impulse was visible on the left fifth intercostal space, just lateral to the midclavicular line. No other pulses visible. No scars, sinuses, or dilated veins. On the cardiovascular system examination palpation, inspector findings were confirmed. Apex beat was on the fifth left intercostal space, just lateral to the midclavicular line, sustained heaving type with medial retractions. Apex beat was diffuse, it was palpable over two intercostal spaces. There's a palpable S4, no other heart sounds were palpable. Percussion, the left border corresponded to the apex and right border was substernal. Left second intercostal space was resonant. On the auscultation, the first heart sound was normal. Second heart sound normal inspiratory split. There was an LVS4 audible at the apex in the left lateral position with the bell of the stethoscope. A harsh ejection systolic murmur, grade 3/6, best heard in the third left intercostal space at the left sternal edge with diaphragm of the stethoscope, crescendo, decrescendo in shape, not radiating to the carotids. Aggravated with standing, valsalva, and reduced with supine posture, and also with hand grip maneuvers. That was a great, yes, sir.
1 minute.
Yes.
About the murmur, harsh
Yes.
ESM. You told everything except the most important thing. What is missing there?
The pitch of the murmur, sir.
Not the pitch. What is the duration of the murmur?
It was an early systolic murmur, sir.
Early systolic. No, duration was only short, is it?
It was an early systolic, long duration murmur.
I did not mention that.
Yes, I have not mentioned it. Early systolic, long duration murmur.
Where is it peaking?
It was early peaking, sir.
Early peaking, long murmur and early peaking, according to you.
Yes, sir.
Is that very common?
Not very common, sir, but I got this.
What does the long murmur mean?
Long murmur duration means that it's generally seen in a fixed obstruction, sir.
No, but whatever it is, obstruction is
severity.
Mild or severe or?
Longer duration murmur tells us about the severity of the murmur.
Severity. So if it is a severe stenosis, where do you expect the peaking of the murmur?
So if it's a severe aortic stenosis, sir, then it's a late peaking murmur.
Yeah, there's no mention of those things. That's the point.
Yes, sir.
Okay, go ahead.
Yes, aggravated with one standing Valsalva and reduces with supine posture. There was a grade 3/6 pansystolic blowing murmur heard at the apex, radiating to the left axilla, heard with the diaphragm of the stethoscope in left lateral posture. Other organ systems were normal. So at the end of my result, my clinical diagnosis is
No, I just wanted to know, are there any additional sounds in systole?
I couldn't hear any other sounds in systole, sir.
Do you expect any?
In my given this case, sir, I don't expect any, sir.
What was the apex like?
It was a sustained heaving diffuse apex, sir. Double apex.
No, was it diffuse or was it double? Double means that
double.
But you said it's diffuse over two intercostal spaces.
I could feel two peaks in that region, sir.
So it was not a diffuse apex. It was a localized apex.
Localized.
So what do you think the two peaks are due to?
So, sir, it's actually the phenomena of LVOT obstruction. So when you get two beats, it is when the contracting initially there is whenever there is initiation of contraction, there is a LVOT obstruction which worsens and then it releases. Same thing which we see with Bisperens pulse, same physiology. That's why you have two peaking impulses, systolic impulses in the Bisperens pulse. Same thing is transmitted as the double apex impulse.
In this patient, do you think both the outward pulses are systolic or one is pre-systolic, other one is systolic? What do you say that? Did you time the sounds to ventricular events?
Yes, sir. So I didn't get the question, sir. Which event?
No. You said there are double beating apex. So both the outward impulses, are they both systolic? Or
they both
one
were
is
systolic.
Other one is systolic.
So both were
Or
systolic.
both are diastolic.
Both were systolic, sir.
Both are systolic,
Yes.
according to you.
Yes, sir.
You also said there is a audible sound, fourth sound.
Yes, sir.
Is the fourth sound better audible or palpable?
It is better palpable, sir.
So you are able to hear but not able to palpate.
Sir, I had palpated it also, sir. There's a palpable S4.
So if it's a palpable S4, then how can it become double peaking in systole?
Actually, sir, they have 3 beats also, sir. So one of them
You said only two beats.
Yes,
right?
sir. Yes, sir.
And then you said both of them are systolic, if I remember right.
Yes, sir.
So how do you explain that?
So in a dynamic LVOT obstruction, sir, there if you describe it as 3 apex beats, then the third one is S4. So I have described that as the palpable S4. Because I could time it to the diastole. The other 2 I could time it to the system. That's why I double apex.
Okay, so what do you summarize?
So in summary, my patient is a 50-year-old male with a significant family history of sudden cardiac death, presenting with exertional dyspnea, syncope, and angina, chest pain, presenting with clinical features suggestive of a severe left ventricular outflow tract obstruction at the subvalvular level, NYHA class 3 in sinus rhythm, with no evidence of pulmonary hypertension or infective endocarditis.
So what are the features in this patient which are against the diagnosis of a fixed obstruction?
So one is, sir, on the history. I would like to divide it based on the history examinations. So on the history, of course, we have
let's confine ourselves to the physical examination.
Okay, sir. So on the physical examination, sir, one is that on the apex beat, which we are having, it's a localized apex beat. It is having double apex beat. The auscultation, I'm getting a murmur, which is it's a rhomboid shaped murmur on the diagram.
You don't give any importance to the nature of the pulse.
Sorry, sir.
You don't give any importance to the character of the pulse.
So
what is the difference between a fixed obstruction and what is the difference between a dynamic obstruction?
The bisference pulse points towards a dynamic obstruction, sir. And the volume of the pulse. Generally, the volume of the pulse in severe aortic stenosis will be low volumes. And here we are getting a characteristic bisference pulse on the general exam. So that is one point. Then the murmur character. The dynamic auscultation maneuvers also help in this, sir. The maneuvers which are reducing the preload are worsening the murmur. And so that is all suggesting a dynamic LVOT, which is not there with the fixed LVOT.
Now, my question was, what are the features in the physical examination that are against the diagnosis of a fixed obstruction? 1, 2, 3.
So one in general examination, the pulses bispherian.
Oh, physical examination, yeah.
So, cardiovascular examination, the character of the cardiac apex, cardiac impulse, also the murmur, the characteristic of the murmur, and the dynamic auscultation which we did on this murmur, all suggest against a fixed obstruction. And the reasons are that the dynamic auscultation, the maneuvers, the Valsalva maneuver, then the standing up, when you stand up, the murmur is worsening. These are all suggesting a dynamic LVOT and not a fixed.
What are the causes of bisvariance pulse?
So one is HCM, sir. And also, sir, subvalvular, if you have a subvalvular aortic stenosis.
What is subvalvular? Fixed obstruction will give rise to a bisvariance pulse? Supposing
No, sir.
No, then? What are the other causes, more common causes than I have seen?
Anemia, sir.
Anemia. Anything more common? Any cardiovascular condition apart from HCM that can give rise to a bisvariance pulse? You see on a day-to-day, very commonly.
Sir, hyperdynamic states.
Which hyperdynamic state? Can you name some lesions which give rise to which can give rise to a bisvariance pulse?
A combination of lesions, rather.
Something in the aortic valve.
But the infective endocarditis.
No, infective endocarditis is an acute AR. So acute AR will usually not have a bisvariance pulse. So what is left? Can a pure AR give rise to BIS variance pulse or a combination of AS with AR?
ASAR, sir. ASAR will give rise to.
So a patient with ASAR has a BIS variance pulse. What will you conclude? Which is the predominant lesion, AS or AR?
AR is the predominant.
So what are the other causes of dynamic LVOT apart from HCM?
There could be a in congenital heart disease, sir.
Like
there is a LVOT, subvalvular ridge.
That will not give rise to a dynamic. That is a fixed obstruction, isn't it? So you get the same murmur. You make him supine. The murmur reduces. You make him stand. The murmur.
There are mimickers of HCM, sir. Pompey's disease.
No. Okay, that is okay. What else? What are the causes other than HCM? What is the cause of this? What is the cause of a dynamic murmur?
So the cause of the dynamic murmur is when there is
the cavity is small and the mitral valve is big, isn't it? A small cavity. So what can be the causes? And severe dehydration?
Yes, sir. In severe dehydrated state.
What happens? When you give inotropes to bring up the blood pressure, what will happen? Hypercontractile?
Hypercontractile. So you have a
hypercontractile with low volume. Okay, that is one. What else? What are the other causes of dynamic LVOT?
Even severe blood loss anemias can cause dynamic LVOT.
No, not really. Okay. What else? Can you have an apical MI or a Takotsubo at the apex? So the base is hypercontractile?
Very severe Takotsubo can present with an LVOT.
And so many times, have you been called by the surgeon sometimes that the patient aortic stenosis operated, the blood pressure is not picking up?
It could be because of an oversized aortic valve that they have placed.
Not oversized aortic valve. Basically, the cavity in the aortic stenosis is very small.
Small.
Yeah, so they give a lot of inotropes post-operatively, and you find that there's a dynamic obstruction.
Dynamic LVOT. Go with the investigation, sir. There's baseline investigation.
Just one more question.
Sure.
I say that it's a dynamic RVOT and not a dynamic LVOT.
So, sir, inspiratory variation can help us to differentiate between dynamic RVOT and LVOT. Sir.
What will the inspiratory do?
Inspiratory variation means during deep inspiration,
yes,
the murmur should reduce.
What else?
Then also leg raising, passive leg raising will reduce the murmur. So,
plus your general examination findings, your apex and all that will obviously.
Right heart failure.
Yeah. Your apex RV.
Yes, sir. RV type apex. Yes.
Okay.
Yes. The baseline investigations, blood investigations were normal. His ECG was done twice during baseline ECG was in sinus rhythm. The axis was about plus 60 degrees. LVH with strain. Second ECG was done, which was showing suggestive of a sinus node dysfunction with junctional escape. And rest of the findings were similar. Chest X-ray was unremarkable. His 2D echo showed.
Can you go back to the second ECG? I think there's not enough time to see it. Why do you say it's a sinus node disease?
Sir, we can't see a P wave, sir. We're seeing a change in the QRS morphology. Looks like a junctional escape, sir.
There's no P wave anywhere?
No, sir. The previous one had a P wave, sir. There were two ECGs.
Second, there's no. You look at look at V6, right? Look at V3. I'm sorry, V3.
Yes, sir.
So look at this. Okay, sorry, no. That's V6. Look at the first QRS complex in V6.
This one.
There's something at the beginning of the QRS which is missing in the second one. What is that?
So here the
V6, there is something at the beginning. You think that can be a P wave or no?
not very convincing, sir.
So why should you have these group beats in a sinus node disease? I mean, do you have
Sir, I didn't get the question, sir.
why should you have alternate beats in a sinus node disease? Junctional escape is never like this. You call it a junctional escape? Why should a junctional escape have alternate?
So one possibility is that he is having a ectopic rhythm, but I'm not able to see the P wave at all, sir. So,
Can you go back to the last ECG? What is the normal, what is this QRS like? Okay, so this is his QRS. Now go back to the next one.
so these seem to be
The first beat are his normal beat and the second
yes,
is
sir.
probably
Second one is an ectopic, sir.
ectopic. Do you think that's retrogradely conducted and suppressing the?
Yes, sir. I feel so.
I mean, junctional escape can. Dr. Narasimhan, sir, is he there?
So, sir, I would like to reframe it. Possibly it's a ectopic rhythm, low atrial ectopic, which is causing this kind of thing.
Yeah,
But,
because junctional cannot be like
no.
this. It cannot be
and
like
it's an
this.
intermittent, sir. It's intermittent because intermittently they are getting a normal QRS also.
Can you go back and compare the previous ECG?
Yes, sir. This is the first ECG. Sinus
Okay, look at lead 1, 2, and then compare it with the so-called junctional beat now. It's completely different, right?
Yes, sir.
So one has got an upward rightward axis, second one is leftward axis.
Yes, sir.
Upward, downward. This is typically seen in delayed after depolarization. This is very typical, like a digitoxicity, even in patients without digitoxicity. I don't know whether this patient received any beta agonist, for example, as an inhaler. There is something that has provoked this. This is a bidirectional form of ectopic, either coming from alternate papillary muscles or more likely from the fascicles, because the QRS is very narrow and you can see alternate beats coming from the fascicles. So this is, you need to go through the drug chart to see what this patient was on. Hypomagnesemia can cause this. Some of the persons who are taking aconite as a supplement will develop this. There are several differentials, but this is not junctional.
So the 2D echo showed so concentric LVH with a SAM with a moderate to severe MR.
Sorry, you missed out the X-ray.
X-ray was the X-ray, sir.
Yeah.
So predominantly looked, I mean, there's no much cardiomegaly visible. But the cardiac ratio is about 45%. Sir. The cardiac knuckle is on the left side.
Any positive finding?
Nothing.
Pulmonary venous hypertension?
Not typical bat wing gain, sir. No.
Bat wing you get in pulmonary venous. What are the early stages?
So in early stages, we'll have some lifting of the, if there is atrial, left atrial enlargement, there will be lifting of the left bronchus.
No, I'm talking pulmonary venous hypertension.
So in pulmonary venous hypertension, we should have some curly B lines.
No, what are the stages?
So first we'll have curly B lines as the early marker. So peribronchial cuffing.
No. Something
Before
else?
curly B line, before.
Peribronchial cuffing, sir.
No, something.
Cephalization of the vessels.
Good. Cephalization. Before that? Even before cephalization?
Equalization.
Equalization. So do you think there is some capitalization in this?
Not to my eyes, sir.
Not convinced. Okay, I think there is. What about the left heart border? You think the pulmonary bay is there, or it's to a straight line? Maybe there is a little bit of bay. I think so. Maybe something. Okay.
Coming to the four-chamber, sir, there is a significant eccentric severe MR, sir, with a LVOTO turbulence.
No, can we start with just describe the first one, plaque. Start with the plaque. Yes.
So the plaques view is showing a LV, which is, there is a concentric LVH with a basal septal, ASH, asymmetric septal hypertrophy. There is
how do you define concentric LVH? So when you say concentric versus asymmetrical, how do you define that?
So, sir, we have to see in the plaques as well as four chamber. We have to look at the thickness. And if in an asymmetric septal hypertrophy, the basal septum is much more thicker than the.
How much? How much? Give a number.
So, I'm not aware of the exact number, sir.
1.5 times.
1.5 times.
1.5 times. So this might be, I mean, it might be asymmetric.
Yes, sir.
Septum appears much thicker.
On the 2D also we can see a SAM. So though I have taken an N-mode image also, but there appears to be a grade 3 SAM. There is a LVOT turbulence on color as well as moderate MR easily seen on the plaques itself. So it looks like a posterior jet, sir, eccentric posterior jet. This was the four chamber, where also we are getting that. So in this scenario,
can you say the four chamber again?
Yes.
The plaques is not good. Yeah, there is a SAM. Correct.
Yes. So though looks like a moderate MR, but will behave like a severe MR since it's an eccentric jet, it becomes difficult to quantify it. This is the.
Is there any evidence of right ventricular hypertrophy on the 2D echo?
Right ventricular hypertrophy, sir?
Yeah.
No, sir.
What is your criteria?
So we look at the RVOT.
RVOT. What do you look for in RVOT?
We look for any RVOT obstruction and thickening, and we look at the RV size, the diameter.
That is for
RV hypertrophy.
RV hypertrophy.
RVH means for the.
So what is the criteria?
So septal thickness on the RV side, sir.
That's not.
Septum is septum. There's nothing on the RV or the LV. Septum is septum.
What is the thickness of the RV free wall normally?
RV free wall, sir. 5 millimeters. Sir.
How much?
I'm not wrong, sir. 5 millimeters. No.
So
is there a.
Sorry.
Go ahead. Is there a RVH or no RVH?
Doesn't look like RVH, sir.
So the free wall thickness, if it exceeds, I not measured it, but if it exceeds 6 millimeters, then it is supposed to be RVH. What is the importance of knowing RVH in a patient like this?
So it basically HCM can present on the biventricular hypertrophy. Sir.
How often?
It is percentage, I don't remember, sir, but it is, I think, almost 20% of the patients. And it's gives a relatively poorer prognosis.
Okay, any other abnormality on this echocardiogram would you like to see? So apart from LVH and probable RVH?
LA volume, sir.
Mm-hmm.
And for the mitral regurgitation.
Interatrial septal thickness is normal or abnormal?
In this patient, it was normal, sir.
Normal. Importance?
Amyloid. In amyloid, infiltrative cardiomyopathies, interatrial septal thickness will be thicker.
Mm-hmm.
Yeah. Let me add here, though classically it was said Enteatrial thickness is more in amyloidosis to distinguish it from other cardiomyopathies. But it is not true. Even in hypertrophic cardiomyopathy, atrial septum can be increased in thickness, that is more than 2 millimeters. And this is very well documented, though not often talked about. And another thing which he is not mentioning so far is the LV filling physiology. Is it restrictive physiology or any other kind of abnormal physiology? LV filling physiology is important for the reason those who have restrictive filling physiology has a very high mortality rate and high complication rate. So that is important to be documented. He also has not made any attempt to look at the papillary muscle and caudal apparatus. 70% of hypertrophic cardiomyopathy have abnormal papillary caudal apparatus. So he hasn't mentioned that. LV apex, 5% of them have aneurysms with or without thrombus. And these people have high mortality. That is what is recorded in the literature. That also he has not mentioned. And he hasn't given a full description of the mitral valve. And he made no attempt to look at the RVOT, whether there is also dynamic obstruction of the RVOT. So there are quite a few things which he has not fully described in the echo. That would be my comment.
Thank you, sir. Sir, I have not finished the echo recording, sir. And in the plaque, sir, the subcaudal apparatus, whichever I could see, seemed okay. I took a short two-chamber also. Papillary muscle attachments.
Papillary muscles are very thick.
Yes, they were thick.
Supposing there's a lot of RVH and right ventricular outflow tract obstruction, what would that indicate? It's more common in what type of condition?
So the inherited HCM.
No, inherited, all are inherited.
No, the syndromic one.
Which syndrome? Noonan syndrome. Noonan syndrome, RVH, pulmonary gradient.
It's more of a
common. It can occur in HCM, sarcomeric HCM also, but
yes,
it's more common. It's very common in Noonans.
Lentigen syndrome is another I would add.
Yes.
Lentigen syndrome also has seen in my own clutch of cases. I had two patients who were isolated, hypertrophic, obstructive cardiomyopathy of the right ventricle. Isolated right ventricular outflow tract dynamic obstruction. First case, we made a bloody mistake of sending him to the surgeon for pulmonary surgical valvotomy. That was 25 or 30 years back when our knowledge was quite limited. And this fellow ended up dying on the table. Then we did a autopsy. Then we found to our horror that he had hypertrophic isolated right ventricular obstructive cardiomyopathy, which was very typical on histopathology. Then we recalled that we made out his lentigens physical examination, but did not connect it with the auscultatory findings of the heart. Then we learnt a lesson.
What is the cause of Noonan syndrome? Just incidentally, what is it due to? Or Leopard syndrome, both of them, what is the cause?
So it's all the male form of Turner's.
No, male, it can occur in females. It's autosomal it can occur in both.
It can occur in both.
Turner's does not occur in males, but Noonan's can occur in both. What is the cause? What is the cause of Noonan's? What is the etiology?
Etiology is the autosomal mutations.
In what?
In the
PNTP.
PNP.
Protein tyrosine phosphatase. Okay. Right.
In this echocardiogram, what you saw, is it related to hypertrophic cardiomyopathy or is there an independent mitral valve abnormality?
So, in this patient, there was definitely, the caudal apparatus, at least on the transthoracic, seemed to be okay, so subvalvular.
What do you mean by okay? Is
okay
it,
means
is
that
it
the
Is it related to LVOT obstruction or is there independent mitral valve abnormality?
Based on the transthoracic, it appears to be driven by the LVOT obstruction because of the venturi.
What is your basis for telling that?
So there is no caudal elongation. And
did you really measure the caudal elongation?
So the plaques and the 4 chambers, sir, we tried to see whether there is any caudal elongation, prolapse, which I could not see.
No, is caudal elongation the cause of mitral regurgitation or abnormal mitral valve in HCM? Is that a common cause?
No, that's not the commonest.
See, it's very important. That question is critical because whether you will do an alcohol ablation or not.
Yeah, exactly.
Whether the MR will disappear with alcohol ablation or do you have to send him for surgery? So you have to take a call. So caudal elongation, I don't think is very common in HCM.
Caudal elongation is not the commonest abnormality.
Yeah.
Sir.
So you have to look at the papillary muscle.
Papillary muscle, sir. So the papillary muscle attachment and the thickness.
No. That my question to you is, based on the echocardiogram what you have shown, do you think it is due to LVOT obstruction or is there a independent structural abnormality of the mitral apparatus?
I feel it is because of the LVOT obstruction, sir.
No, what is your basis for that? We understand.
There is SAM. There is a significant LVOT obstruction. Papillary muscle attached to the thickness. Apart from the thickness, there is no other subvalvular abnormalities.
So is it type of MR? Is it a central?
It's an eccentric.
Eccentric MR.
Eccentric MR, sir. Posteriorly.
So what does that suggest?
So if it's because of the venturi effect, it will be an eccentric anteriorly directed or central jet MR.
If it is structural abnormality?
It could be, it is eccentric.
So that's one of the things. Can you make out on physical examination whether the MR in this patient is related to LVOT obstruction or to structural abnormality at the bedside?
Yes, sir. So if it's a functional MR because of the LVOT and if it's an anteriorly directed jet, the direction of conduction of the murmur, radiation of the murmur is opposite. And from the apex anterior.
That's not true. Suppose if the LVOT murmur decreases and the MR murmur does not decrease, what do you conclude?
Organic MR.
So that's the way it is. Because you did the dynamic auscultation, you said only the LVOT murmur. You never said anything about the MR murmur.
Yes.
Suppose if the MR murmur does not decrease, with the decrease in LVOT murmur, then we have to suspect that probably there is an additional structural abnormality. And thus, that is going to determine your future approach for the management of this hypertrophic cardiomyopathy. It's important. How many papillary muscles are here?
2, sir.
You're sure?
Yes, sir.
Mm-hmm. What are the papillary caudal abnormalities that are described in hypertrophic cardiomyopathy? 70% of them have, but what are the abnormalities? Have you looked for them? Or what is the best way to look for them? So, it is extremely important for the reason that if there is important abnormalities, then your septal ablation is not going to help the patient. So he will become a classical surgical patient.
So in 2D echo, sir, 2D echo is the modality which we can use to look for the...
No, it's not 2D echo. The gold standard is the MRI.
Okay.
So the 2D echo is okay, but not very reliable. The best way of looking at them is by cardiac MRI. But anyway, what are the anatomical abnormalities? First, you should know that to look. If you want to look for that, you need to know what you are looking for.
So the papillary muscle insertion thickness.
No, you are just reeling off some vague words. What are the exact abnormalities?
I'm not aware of the exact abnormalities.
You are aware of it or not aware of it?
Not aware, sir.
Okay. I think let's move.
So you will see the papillary muscles are displaced anteriorly and superiorly, and sometimes the obstruction is not only in the LVOT but also at the papillary muscle level, papillary muscle caudal level. So this becomes a very important consideration to decide whether it is surgical, referral, or is it a septal ablation procedure. So this will become clearly a surgical procedure where surgeon is going to do not only the septal myectomy, but also rearrange the papillary muscles and then shorten the chordae and then also decrease the interpapillary distance. So there are other methods which they employ depending on the type of abnormalities. So it is very, very important to be part of your protocol to examine the hypertrophic cardiomyopathy. Just as right ventricle also. A lot of people don't look at the right ventricle and RVOT, and almost nobody from many centers look for the papillary caudal muscle apparatus abnormalities or the LV aneurysm. Thereby the diagnosis, anatomical, physiological, is incomplete. Did you look for the restrictive physiology of the LV inflow filling?
Yes, sir. In this patient, I got a grade 1 diastolic dysfunction with normal LV filling pressures. Of course, patient was well fed at this stage, sir. So
no, what is the mitral? Spectral Doppler. What is the deceleration time?
I think you need to ask them. Explain first the physiology of restrictive physiology. What do you expect if it's a restrictive physiology on the Doppler?
Yeah, just saying grade 1, grade 2 does not convey anything.
So we look at the color of the pulse width Doppler across the mitral wall, sir. We look at the E velocities, A velocities, and the relation of the...
Please speak into the mic. We are not able to hear it properly.
We look at the A velocities, early and late A. We look at the EA relations. Less than
what
one,
do you look for? What are you looking for? Give the values.
So the values is that if you're looking at E, if E velocity 54, or more than 54, then one is you look at the EA relation, less than 0.8.
No, sorry, you said E54. E54, more than that is very common.
Sir, I'll explain, sir. It is E and A relation less than 0.8, 0.8 to 2, and more than 2 for grade 1. For if it is less, if E is less than A.
No, we are just saying restrictive. That's all. Don't describe grade 1, grade 2. Restrictive. So what are the features?
So EA more than 2, and there is increase in LV filling pressures. E by E dash more than 15. LA volume is more than 34 ml per meter square. And
wait a minute. I think we are talking about mitral Doppler filling pattern, restrictive pattern. So we'll have to say three things. E by A ratio more than 2.
More than 2.
1. Yes. E wave deceleration time 130 milliseconds or less. And IVRT less than 60 milliseconds. Yes. So you need to say only these three things. What Raju is asking is describe the, restrictive filling physiology. So you need to tell about the hemodynamic parameters measured on the Doppler and say what constitutes the restrictive pattern. Restrictive pattern means usually LA filling pressures are high.
Yes, sir.
That's why we say restrictive filling pattern.
So, but there is one query here, sir, that when you have very high E velocities, the deceleration time normally is longer. So whether we should take that into consideration, because that is what many of the books and many of the echocardiographers have been saying. If you have very high E velocities, the deceleration time, even in non-restrictive pattern, will be more than the cutoffs.
No, we are not talking only about two parameters. We're talking about three parameters: E by A ratio, E wave deceleration time, and IVRT. If all the three are present, then it is what we call restrictive pattern.
Yes.
Okay.
Yes.
So what is the implication of that? prognostic therapeutic?
Sorry, sir.
What is the implication of a restrictive fill-in pattern in the management of patients with hypertrophic
Patients with restrictive filling patterns in HOCM have very poor prognosis because they have, it's a irreversible form of diastolic dysfunction which is developing. So in terms of mortality, it's high.
No, give numbers. I mean, give an idea that supposing a patient with HCM, you have diagnosed a restrictive filling pattern. What is the outcome? What is the 5-year outcome, 10-year outcome? Give some idea. Give some rough idea.
So mortality in terms, 5-year mortality is more than 50%.
No. What are the things? What are the risks which are common? Atrial fibrillation is more common.
Atrial fibrillation, heart failure. Heart failure.
1/5 will, so only a 5-year follow-up, 1/5 will go into atrial fibrillation. What else? Heart failure is more common.
Heart failure is more common.
And what is the 10-year? What is the 10-year without heart transplant survival? It's around 50-55% is the 10-year survival. Which is much worse than for an average HCM, no? These are young patients. So 50% 10-year survival is very poor. So you said something about deacceleration time being long. In a restrictive, the deacceleration time is short.
So what they are saying is that in when the E, since we have to keep a cutoff, so we keep a cutoff of 130, sir. And in the restriction, it is more than 130. No, sir.
No, restriction is less. The deacceleration time reduces.
Correct.
Reduces.
So
that's what I'm trying to say. That a deacceleration time is short in a restriction. It's not long.
Yes.
That is it.
I think we should move along.
So the cardiac MRI findings were showing a late gadolinium enhancement in the mid and apical septum as well as posterior wall of the LV with a total scar burden of 10%. And the dimensions were at base, mid, and epicenter dimensions were 20, 18, and 16 with HOCM and ESM. The 24-hour Holter was done to look for any events. So there was no evidence of any VT or atrial fibrillation. And during this 24-hour period, there was no sinus dysfunction which we could record. So,
what do the guidelines say about duration of Holter in HOCM?
So the current, I think ACC-AHA 2020 guidelines which were released, they have given specific indications as well as duration for a 3-day Holter, 7-day extended monitoring, sir.
Yeah, so you have done only 24 hours.
Yes, sir. We did it only 24 hours, sir.
Yeah.
So my final diagnosis was a hypertrophic obstructive cardiomyopathy, severe mitral regurgitation, functional class LYT3 with the ECG evidence of sinus node dysfunction.
No, that you said, that you refuted right now, no?
No, sir. Only I have a documented ECG. One documented ECG we have to accept it, sir. Because that's why the guidelines have now included 3 days and 7 days holders. That was an error on our
But you have not shown us that ECG. Sinus node dysfunction.
So the one that we were discussing, sir said it's a particular origin PVC.
Okay. Right. That's fine. That's okay. Go ahead.
Can you go on to your MRI thing? Because MRI is the gold standard in hypertrophic cardiomyopathy as of now. And your findings are very, very abbreviated. You haven't mentioned anything about the mitral valve. You haven't mentioned anything about RV. You haven't mentioned anything about left atrium, intraatrial septum, papillary cardial apparatus, and LV apical aneurysm. In fact, cardiac MRI indication is not only for gadolinium enhancement. That is one, of course, a major input. But there are other things which can be made out so well in cardiac MRI. That is the reason why it has become a gold standard. So your whatever slide you are projecting here does not contain any of them at all. Does it mean that you have not looked for it or you have not represented here?
So for the want of space, sir, I have not represented them here. Whatever was reported was that there was no RV was normal. There was no RVOTO. LA volume was similar to the one that we had already seen on the.
You can't say that there is no space because that is the gold standard investigation. You should have shown some images of cardiac MRI, representative images, and should have given a complete description. But this only will give us information that your evaluation is incomplete and it cannot contribute to your final diagnosis and it cannot support your management as well. Because there are too many things which may be wrong, which you can make out only on MRI, and they are the reasons why you choose a particular treatment over another. Not acceptable. Just like your 24-hour Holter is not acceptable, it should have been longer, not less than 7 days. So this also is very, very incomplete, and there are no images which you are not showing. May I ask you that whether this is a report which you have just copied from your radiologist report, or you took the, time off to look at the images yourself?
So I sat with the radiologist, sir. Since I'm not very conversant with MRI, I sat with him and he has given me these reports.
But isn't it mandatory for you to be conversant with MRI? After all, it is cardiac MRI, not brain MRI.
Sir, I'm actually trying to learn for it. I've not mastered it yet.
You can't learn this thing from radiologist. Radiologists are not the best persons to interpret cardiac MRI or cardiac CT or nuclear cardiology. They have only very, very basic knowledge. You are the person who have the best cardiac knowledge to interpret. You know the cardiac anatomy, cardiac physiology, cardiac pathology, cardiac variations. You know what to look for. They don't know all these things. So if you are going to learn from general radiologist, you will end up like a general radiologist, which is close to nothing.
So
Did
what-
I tell you that? Do
Sorry,
you understand?
I think we'll move along. I think.
So what type of scar do you get on LG and what type of scar do you miss on LG? So deep gadolinium, yes.
Transmural scar, sir.
No, you can get a subendocardial scar on LG, you can get a mid-myocardial scar. So what is
Epicardial scar, sir.
No,
No.
just see the question. What type of scarring? What does LG do?
It's it's a late washout. We look at the late washout after the first cycle.
So how does it decide what is normal and what is abnormal?
Based on the surrounding
Good. So what it picks up is localized scarring. So if there's diffuse scarring in the myocardium, it will not get picked up in the LG. Yeah. So how do you pick up diffuse scarring in the myocardium? And what in a MRI?
What parameters?
What is the type of imaging? What imaging do you use?
T1 mapping.
Good.
Did your study include ECV estimation?
Extracellular volume.
So I was not aware of that. So I talked to the radiologist and he showed me.
But anyway, not being aware is not a crime, but not trying to be aware is a crime. So you better, particularly when you are in a national hookup, presenting a particular type of case, I would have expected that you go through some of these things and be ready to answer or question us. Extracellular volume is a very, very important parameter in cardiomyopathies. Do you know the concept of replacement fibrosis and interstitial fibrosis?
Yes. Basically, when you have destruction of the cardiac myocytes, there is replacement fibrosis, so destruction of the cell, and there is fibrosis. And interstitial fibrosis is when it is between the myocyte in the interstitium that there is fibrosis.
Which is worse?
Replacement fibrosis.
Yeah.
No.
So go ahead. And the answer to the previous question, the scarring in the RV also is very difficult to make out by gadolinium enhancement unless RVH is present. Because RV muscle is so thin, you can't get the scarring there seen on the MRI. But if there is RVH, right ventricular free wall hypertrophy, then you can make out the areas of gadolinium enhancement. Another area where you have to look for is the left atrium and right atrium. So if there is gadolinium enhancement of the atrial walls, then that is almost a sure shot sign of near future atrial fibrillation. Go along, please.
So the final diagnosis was we can't hear you.
Phone is ringing or anything, just mute yourself.
Sure. So finally, we came to the management, sir. So problem.
You said high risk for sudden death. So what are the features? Go back. Significant risk for sudden death. What is the significant risk of sudden death?
Unexplained syncope. Of course, not with this patient. I'm talking in general.
No. You're talking about this patient only. So
there is syncope, family history of sudden cardiac death. Then also MRI, though it's not a risk factor per se, but definitely it is included. So more than 15% they talk. But that is a gray zone, sir. It has to be taken into an NSVT documented.
There was no NSVT on Holter. So in this, there are only syncope and family history.
Syncope and only family history.
Okay.
But as I understand, even one event of syncope, unless you definitely have any other explanation for that, in a patient with hypertrophic cardiomyopathy, with history of precocious sudden cardiac death of his father, I think he is perfectly fine for an ICD.
So he was advised surgical myomectomy in view of his symptoms, LVOT obstruction, on-table decision for an FVR, and an ICD prior to discharge. So
here, did you look for any additional mid-myocardial obstruction?
In this
apical or mid-myocardial?
In this patient, I tried to look for it pre-operatively, post-operatively, both ways, sir. Pre-operatively, I couldn't find it because the CW jet, the PW here was kept aliasing. So, and post-operatively, when I checked.
But you can make out an MRI. If you had trouble with Doppler, you can make out very clearly on MRI whether there is a mid-ventricular obstruction or not.
So MRI, they showed us that there was no obstruction, but on the echo, I'm saying we couldn't.
Presuming they knew what they are talking, taking it at face value, but I wouldn't take it at face value if the report has come from radiologists. So you need to be good at reading it yourself. Okay, go on.
So since he was offered a dual chamber ICD, however, he had severe financial constraints. So he had to, he couldn't afford an ICD at that point. So it was discussed with our heart team. And it was decided that we'll put a dual chamber pacemaker for the time being till he arranges the funds in view of his bradycardia and some sort of dysfunction discussed. We implanted the pacemaker. However, day 2 of the PPI in the hospital, he developed a repeat syncope with palpitations. And the ECG documented a monomorphic ventricular tachycardia, LBBB, northwest axis, and negative QRS morphology in 1 AVL. So, since he had a documented ventricular tachycardia now, and with this preceding HCM diagnosis, we decided to upgrade it to a dual chamber ICD. We got a donor, and we upgraded to a dual chamber ICD, discharged him on beta blocker therapy. Now, 6 months follow-up, there's no recurrence of VT, syncope, device parameters are normal, and he is also become NYHA1. And his post procedure, we did the echo recently. The gradients have come down to 35.
How much? What was the gradient?
35, 130 to 35 now.
But did you do a stress diastole?
I didn't do a stress, but he had come starving. I had called him starving. So that's all. But yes,
no.
I didn't do a stress. I didn't do an evocable.
Any LVOT gradient in such kind of patient without a stress study, either physical stress or pharmacological stress, is incomplete.
We did a Valsalva, sir. This was post Valsalva.
The 35 millimeter is post Valsalva.
Yes.
Is that so?
Yes, sir.
Which
So
phase
would
of
you classify the surgical result as good, poor, or excellent?
Classified as good, sir.
Good. That too with a residual gradient of 35.
Yes,
that basically appears to be at rest. So if you exercise him, this 35 probably may even become 80 or 90 or something.
yes.
Do you agree?
Yes, sir.
Did you do a mitral valve replacement?
Yes, sir. They did on table on the in the operative room.
So if you have a mitral valve replacement, SAM is impossible. There's no anterior valve. And what is the cause of the gradient?
So
I mean, there should not be any LVOT gradient. Once a mitral valve replacement is done, you can't get a SAM. So you can't get a
SAM. But if there is a mitral valve, and if the ASH, they only remove the septal thickness only at the point of coaptation. So there will still be, it behaves like a so-called fixed, not fixed, but something like a fixed LVOT.
It is a fixed LVOT, absolutely. It has to be a fixed.
So there is a gradient coming, sir.
Before surgery, could you have tried some drug?
So, sir, ideally, medical therapy, even now in the guidelines, is the first line therapy. Beta blockers, followed by that diazoparamide. And so these two are currently considered. But in this patient, because of the rhythm disorder, and that was the reason why we did not put him upfront on beta blocker therapy. And we went straight away for a surgery.
Right. So what are the precautions you take before putting a patient on diazoparamide?
The VT risk, QT prolongation.
You monitor the QTC. So when do you stop? So suppose you started a patient on diazoparamide. When do you stop diazoparamide? If the QT exceeds?
470, sir.
How much? No, you don't stop it. It very commonly goes 470. 500. Okay,
500,
what else?
500.
What are the precautions? What are the things that you ensure?
Even, sir, in patients who have BPH.
BPH, very good. So you will exclude BPH because there will be urinary retention, anticholinergic. Yes. What else?
And generally we give it in conjunction with beta blockers.
Not generally, always.
Always.
Why? Why can't you give diazoparamide separate without a beta blocker or a verapamide?
So it is a...
it's contraindicated in the absence of a beta blocker or verapamide. Why? What does it do to the AV nodal conduction?
It is a AV node blocking it. I mean,
no.
Non-AV node block.
It anticholinergic. It accelerates the AV node conduction.
So we have to give a beta AV node blocking agent.
So what happens if a patient develops atrial fibrillation on diazoparamide without a beta blocker? It can go into very rapid rates and degenerate into VF. What else? One more precaution that you need to do before starting diazoparamide, especially in older people. Glaucoma.
Glaucoma.
Right? Can precipitate glaucoma. So that you should generally have an eye. Okay.
So
yes, sir.
I have a question there. There is a postoperative residual gradient. Now, what are the possibilities? Why is there a gradient? Is it that it's an incomplete resection or any other reason?
So one could be, sir, that there is some mid-myocardial, as you said, that there is mid-myocardial obstruction which was missed.
Can you show the post-op echo? Is it recorded? Does this play?
No, sir.
Is there a 2D? It doesn't play. Okay.
the possibilities are, of course, the incomplete resection is one possibility. The second thing, as we have been discussing, it could be mid-myocardial or papillary muscle level obstructions.
Yes.
Or even more provocative thing for me is whether the mitral valve, prosthetic mitral valve, if it was prosthetic valve, that itself could be obstructing the left ventricular obstruction, depending on the location of insertion or orientation of the valve. So there can be gradient because of the prosthetic valve itself. Because the cavity is small in hypertrophic cardiomyopathy. So the size of the valve which you have chosen has to be very carefully chosen to match the size of the LV, also the annular dimensions, mitral annular dimensions. So if it is too big for that particular ventricle, then that might give rise to LVOT gradients. And that is the reason why intraoperative transesophageal echocardiography, I don't know if your center has done that for this particular patient, but during surgery, intraoperative TEE is mandatory to look for all these things.
Narasimhan, your final comments and...
Nothing, sir. The patient, this is to highlight the complexity of several of these patients have concomitant mitral regurgitation. So imaging is very crucial to understand whether to send these patients initially for percutaneous procedures or surgery. Whenever the mitral valve structural changes are noticed and you deem that a patient is going to require a mitral valve correction, it's important to send them upfront for surgery rather than trying a percutaneous method. Second is relief of outflow obstruction does not mitigate the risk of sudden death. When they have significant mid-myocardial scar, family history, and other things, as this patient has shown, that despite a correction of the outflow tract obstruction, he had VT and collapsed in the hospital and required resuscitation. And further, I think this patient had a post-operative sinus node dysfunction. That's very unusual. When the surgeons in small size, some of the left atrium, they have a superior approach. They go through the roof of the LA. The node gets ischemic because the sinus nodal artery traverses through that. And that may be the reason why this patient developed a post-operative severe sinus node dysfunction. I think I'll ask Dr. Muthaiya to present briefly on the HCM and some of these aspects.
Thank you, sir. Thank you for the invitation. Basically, regarding this case, we thought we'd just highlight two, and many of these points have already been discussed. So I'll just around 15 to 18 slides, and I'll just try to highlight a few important clinical points. The two things we thought we'll discuss is one, contemporary management of LVOT obstruction. And now with disopyramide being readily available, and which patients we should send for a septal reduction procedure. And the second point is, especially in this patient, what does septal myectomy actually do to the SCD risk? Does it stay the same or does it decrease? So I think the point was made really about the elongated mitral valves and how they have a effect on the LVOT obstruction. So these patients with hypertrophic ventricles, they have already a small LV cavity, and really analyzing the mitral valve apparatus with, especially because two kinds of mitral elongation has been described. One is the AML being elongated, but there are a certain subset of patients like this one where you can actually see the PML also plays a role in the LVOT obstruction. So in these kind of patients, you can't take care of only the AML, you have to do something for the posterior mitral leaflet as well. And and I think, as Krishnamraju sir has said, the MRI has really changed the way that we have started looking at the papillary muscles and other forms of LVOT obstruction as well. So the mitral valve, in terms of, and I'll show a few echo and MRI pictures, the few things that we find is the abnormal papillary muscle anatomy, the abnormal papillary muscle attachments. Sometimes you see very long anterior, like almost cord-like structures because the papillary muscles are so basally attached. Elongation of the mitral valve leaflet, both the AML and the PML, all contribute to this MR. So I think, and oftentimes we see that these things work at rest and exertion slightly differently in terms of the way that they produce their mitral regurgitation. So even in context of this patient and the mitral regurgitation, really looking at the MR, what is the mechanism of the MR, because in terms of counseling these patients also, it's a completely different counseling when you talk to them about only septal myectomy or septal myectomy with a mitral valve replacement in terms of cost and in terms of overall risk of the procedure as well. So here we see a typical patient with a sort of LVOT subvalvular obstruction. And then in the center, we can see a patient with a mid-cavity obstruction. This is an important differentiation to make because so mid-cavity obstruction patient, there are two issues. One, surgical relief and the surgical technique used for a mid-cavity obstruction is slightly different and slightly more challenging sometimes than a basal septal reduction technique. Also, in terms of SCD risk, these patients with a mid-cavity obstruction often have an apical aneurysm or akinetic apical segments with a lot of LGE and a lot of potential arrhythmic risk. So identification of whether, and some patients we see they have both levels of obstruction in both the subvalvular region and the mid-cavity region. So in these kind of patients, when you try to relieve the LVOT obstruction, it has to be a comprehensive approach. So we have to do what we can best for the patient. And on the right, this is just to show that sometimes you can have these abnormal apicobasal, what to call them? They're like muscle bundles, apicobasal muscle bundles, and they often attach these muscle bundles. So in this patient, the obstruction is not caused by the mitral valve apparatus per se. It is caused by these abnormal bundles with a very basal papillary muscle. So these kind of abnormalities is being very well picked up with cardiac MRI, and that is why, like Sir said, it is a gold standard when we're working up these patients and deciding what their best line of management is. And in terms of the principles of management, it has changed over time, maybe more so in the last 7 to 8 years. But the algorithm suggested in 2008 was if you had a symptomatic patient with obstruction with HCM, we would try a beta blocker. If the patient didn't tolerate a beta blocker, you would try verapamil. You would go to disopyramide and then try mechanical therapy. Some of these things have remained the same. Still, beta blocker is still the first line of drug, and we try to titrate this to a maximally tolerated dose. And I think Ajay Balsar has already made a lot of good points regarding the use of disopyramide. There are a subselect of patients where disopyramide is slightly harder to start, QT prolongation 1, but generally these older patients where you suspect BPH, that they won't tolerate the anticholinergic side effects of disopyramide, it's slightly harder to start this drug. I would like everyone's input on what their starting dose of disopyramide and beta blocker is, at which point you sort of stop up titrating the beta blocker and add on the disopyramide. And in terms of disopyramide, the other aspect that we also need to look at is the antiarrhythmic effects of disopyramide as well. But in case these patients are, so this is where this classification has changed. Before it was a class 1 indication, the class 1 recommendation was you start with drugs. Now there are a group of the ESC guidelines where they advocate that a septal reduction therapy is a first line therapy for someone who's having a resting or provoked gradient more than 50 who's symptomatic. So it is two ways to look at it. I think still in our center, we still try with a medical therapy beta blocker plus minus disopyramide, and then we talk to the patients regarding septal reduction therapies. Just one slide, because the beta blockers in HCM have been used since 1960s, and this was actually the first report of the beta adrenergic blockade all the way in 1964 in a patient with hypertrophic subaortic stenosis. And so the mechanisms where beta blockers and why they remain the #1 drug for a HOCM patient if they are able to take it is mainly the negative inotropic effect of the beta blockers and the reduction in the wall tension. And the most important part is, I think, that we would have realized that because of the dynamic nature of the disease and the way that it's affected by exertion as well, the beta blockers effect, and that is what they described in 1964, it reduced the subaortic extrusion immediately during and immediately after exercise. So this is usually when these patients are most symptomatic. Disopyramide, and I think Sir has already discussed this, as it works basically as a negative inotropic agent, and it improves in some patients the myocardial ischemic burden as well. So the few things, if the patients are able to tolerate a good dose of disopyramide, it works very, very well in some patients. But unfortunately, there are some patients where QT is affected, or else they have some other comorbidities that don't allow us to prescribe them disopyramide. But in terms of availability of disopyramide, I think it is no, I wouldn't say readily available, but it can be. Most patients have access to disopyramide. Our one limitation in India is we don't have the sustained release preparation of disopyramide that is available in other places. But in this kind of patient where you've tried medicines and you don't know, and it's medically refractory LVOT obstruction, the things that we often discuss with these patients are symptoms, surgical risk, what do we anticipate after surgery? And this often has to do with other things like their comorbidities, including atrial fibrillation, and quality of life and the overall cost of the septal reduction therapy. In terms of alcohol septal ablation outcomes, I think there was always a discussion regarding alcohol septal ablation versus a septal myectomy. But now that we can see that long-term outcomes of alcohol septal ablation, there is most patients, they require re-interventions. The chance of arrhythmic risk post an alcohol septal ablation is definitely higher than a good septal myectomy. And the overall survival, if you see 5-year survival, is still around 95 to 96%. So it is not meant for all patients, but in patients where either they are not willing for or they are not good candidates for septal myectomy, it is a viable option. The one thing is a good coronary angiogram is required, because sometimes the anatomy you need to have a large septal perforator, that is, and this suitable anatomy has to be present before we talk about alcohol septal ablation for these patients. This is one thing that is sometimes overlooked, that when we actually do an alcohol septal ablation, in terms of patients already having an arrhythmic burden in terms of scar, you are now delivering you are now introducing more arrhythmic potential in these patients. And a few retrospective studies have also showed that there are more arrhythmic events in patients after an alcohol septal ablation versus a myomectomy. But the other sort of thing here is the overall populations and how much LVOT obstruction reduction that you have achieved as well. So in terms of choosing surgical myectomy versus alcohol septal ablation, we can take everyone's opinion as well. The better form of LVOT reduction per se and with long-term clinical benefits is probably a surgical myectomy. But for patients where either the surgery is not available, they're not willing, cost is an issue, alcohol septal ablation they do have reasonable outcomes. The only things are in terms of their baseline bundle branch block status, whether they will require a pacemaker, what are we doing to their scar, whether their arrhythmic risk increases. These are all things to be considered. And in terms of other therapies that are now available for patients where you feel that septal myectomy may not be a candidate, septal reduction with radiofrequency ablation has been tried in a set of patients, and we've been able to show reasonable long-term results with this kind of procedure. And now that we have integrated software with the 3D mapping system and with the CT and MRI, it does help outcomes as well. And in terms of pacing, there has been a lot of thinking back and forth whether AV sequential pacing from the RV apex helps reduce the gradient. And although the effects of per se, it does remain inferior to a septal myectomy in terms of long-term LVOT reduction therapy. But in patients who already have a dual chamber ICD or a dual chamber pacemaker, this kind of therapies are, it is something that can be looked at, because there is some definite evidence that pacing from the RV apex with the AV sequential pacing does affect your septal anterior, the timing of your SAM, and thereby your LVOT obstruction. And the new molecule that we are seeing with mavacamten, even though it's prohibitively remains expensive, is that in patients with, it has affected the exercise capacity and the LVOT obstruction. The only caveat that still remains on this randomized trial is on patients who are on maximal doses of beta blockers, they are still not able to show that mavacamten really made a difference to these patients. So it rather highlights that a good dose of beta blockade and if possible, disopyramide is also a good medical options for these patients. The last question, the last 3 slides that I'll show is regarding this SCD risk after LVOT gradient reduction. In summary, this is what the AHA 2020 and the ESC 2014 guidelines term as risk factors. You can see that the AHA guidelines, they don't really talk about LVOT gradient as an additional risk to SCD or SCD risk stratification. They talk about syncope, NSVT, wall thickness, family history of SCD, and these additional risk factors of LV dysfunction and LV apical aneurysm or extensive LGE. But the ESC risk score does take into account this LVOT gradient. And the reason why they do is there are certain papers that say that rather it's not a, and I'll show you 1 or 2 of these studies. So this is an old study, JACC 2005, where they showed that in patients, this was roughly around 1,300 patients from Mayo Clinic. What happened to the overall SCD risk after myectomy in a non-operated obstructive patient and in an operated obstructive patient? So in patients who underwent myomectomy, there was a significant improvement in the survival free from sudden cardiac death. So LVOT reduction does have some effect on the SCD risk, but does this apply to all patients? This is slightly more contemporary, and I think this is, we're seeing more and more large studies, which is good in the recent time. So in 2018, they showed that when you did surgery versus no surgery in patients with HCM, that there was a marginal benefit in terms of sudden cardiac death. So does this apply for all patients? Because we are seeing in our patient, in a patient with HCM that was operated, within 2 to 3 days, he had a collapse, which was due to a ventricular tachycardia. So what are the mechanisms in which an LVOT gradient reduces SCD risk? One, these are just a few things that I have mentioned. One, I think that myomectomy removes a substantial amount of the hypertrophic muscle, but this again is with a limitation. The hypertrophy and the scar may not be in the operated section of the septum. It's most often these patients have scar that is beyond the septum in multiple territories, and this scar makes them still remain arrhythmic. You are relieving a long-standing pressure overload that may lead to further hypertrophy and scar. So that may be one of the mechanisms in which it can possibly mitigate the risk. And a reduced obstruction may reduce ischemia, which may think. So overall, I think you need to assess each patient separately post-myomectomy regarding SCD risk. There still remains a gray area, and I'd like everyone's opinion if we have a few minutes regarding what they think about that. But thank you.
I just have a few things to talk about here, couple of minutes. In the presentation, I did not find any mention of doing a coronary angiogram in this patient because he had a classical angina and there was a premature death in his father. Apart from the HCM, 20% of them are known to have significant coronary artery disease. So was it done and not presented here or not done at all?
Sir, it was done. It was done in another center.
It was done and is presented.
Did he present? Okay, I did not hear it.
Yeah.
Now, the other comment is, Dr. One of the first operations done in these patients was mitral valve replacement by Dr. Denton long back, even before we knew what is this dynamic obstruction and what is the pathophysiology and what can be done, etc. One of the first procedures that was done was plain and simple, straightforward mitral valve replacement. The procedure, like myomectomy surgical, came much later on. The another word of caution is the verapamil. Verapamil is very frequently used, but some patients who have a severe LVOT obstruction, if you use verapamil because of the vasodilatation, actually they may develop acute pulmonary edema. We have had at least 4 or 5 patients who developed an acute pulmonary edema and a crisis situation where we had to struggle to bail them out. So that is one caution which I would tell you about usage of verapamil. And then another thing which I can say is there was a talk about beta blockers, which Dr. Muthai Subramanian was also mentioning. So in the early days, something like in the 80s, the propranolol which we were using, that those days we were using only propranolol. So we were going up to a maximum of 4 grams per 24 hours every day, up to 4 grams. That is 4,000 milligrams of propranolol. But then, of course, over a period of time, we are using different types of drugs. So the combination of disopyramide and beta blocker, the basis explained is the disopyramide reduces the resting gradient and beta blocker reduces the effort exercise gradient. That is the reason why that is a good combination. So those are the few comments which I would like to make. But in the presentation, I think quite a few important things were left out by the student. I hope that he now realizes that he has to see the MRI himself and discuss with somebody who knows about it, and then hone his skills of looking at cardiac imaging by himself rather than depend on a general radiologist opinion. Thank you.
One of the conditions laid out before you prescribe a CCB, calcium channel blockers, is that if during exercise test, if there's a fall in the blood pressure, it is said that you should never use a calcium channel blocker in those patients. Probably that's one of the things that we do sometimes do exercise tests in these HCMs for various reasons, including the precipitation of arrhythmias and the response to the electrocardiogram. But if there's a fall in the blood pressure during exercise tests in a patient who is not on any other medication, is a contraindication for usage of calcium channel blockers. That is one of the guidelines mentioned later. Anybody else has got any other? Dr. Bain?
Overall, the risk of death in hypertrophic cardiomyopathy is not as bad as we used to think, say, 15 or 20 years back. Now the figures say it's roughly about 8% or so in the high-risk patients, less than 10% and about 8%. The low-risk patients, as categorized already by Dr. Muthaiah, is something like 2 to 3%. So that risk stratification is important. And they're also now trying to look at the genotyping and see whether you can pick up the high-risk patients from the genotyping. Of course, it is not very successful as yet, but they have some clues that certain types of genotyping have a higher risk of sudden cardiac death rather than the certain other genotypes. So as you know, there are at least more than 2,200 mutations and 13 genomic abnormalities in this condition. And it is very expensive to test it also. We have the facility in Hyderabad. It takes more than 25,000 rupees to genotype them, but sometimes we do.
Please. Sir, regarding disopyramide, unfortunately, it's available as a capsule in 100 milligrams. So there's not much that we can do with the dosage. Sir, and the genotyping cost is constantly coming down. Like a few years back, it was 50,000, then it came down to 30, 20, and now we are getting it done for 12,000 from a reasonably good lab. So the
That's
cost
right.
every year it's coming down.
Yeah, one of the companies in Hyderabad, I'm actually on their board of governors. So when I requested them to bring it down, it took a couple of years now. It came down from 25,000 to 15,000, 15 now. But the issue is more financial issue is one. Another major issue, another roadblock which I encounter is the family itself does not want to get it done for the family screening. They don't want to know the risk for various social reasons and marital reasons, psychological reasons, you call whatever it is. They never talk frankly about it. But the parents are not very keen to get the family tested. Or the proband's family shies away from getting it tested, though we tell them I will recommend you to get it done for 10,000, but still they are not interested.
Ajay, it's more not a comment, it's more a request. I think before the mavacamten comes to the country, I think you are in a position to kind of do a multi-center trial comparing disopyramide with the same trial, the way they conducted mavacamten. I think disopyramide will be as good or even better. The reason why this is important is if we don't provide data, by default, it will be pushed as class 1 recommendation mavacamten, and every patient is running around for mavacamten. They read something in the Google and then they'll come asking for mavacamten. So,
and basically both are negative inotropic effects, and
right.
so the effect is the same.
So
Not
it's
really. Mavacamten is a anti-myosin.
Yes.
The unfolding of the myocyte thing, myofibrils, is folded.
that's right.
So the locking of the actin myosin is improved. That is the mechanism of the new drug. But disopyramide is completely different. But to answer Dr. Narasimhan, there was a study done by, I don't remember which group, intravenous disopyramide, right? And they have shown excellent results. Following that, when I was working in Osmania Medical College, we did a oral study, not published. You know the difficulties we have in publishing of papers. So we did not publish it, but we have done this study in about 50 patients. There was, except 2 out of 50 patients, 48 patients have reduced their gradient to almost 0 to less than 20. So it is a very, very effective drug. One girl who was 13-year-old nearly stumped me because when we studied her gradient, it was 180, 180. And then I said that you give her one capsule of 100 milligrams of disopyramide. They gave it to her. After I completed my round, which would generally take about an hour or so in Osmania, then when I went back and examined her, there was no murmur.
Fantastic.
The pre-drug murmur was grade 5 with a huge thrill. So I was so foxed, I immediately got the study done and the gradient was 0, 180 to total 0.
Fantastic.
Both were resting, of course. So sometimes it can be very, very dramatic.
Yes.
And I have another observation I have made. One of the patients, which Narasimhan also knows, there is an art director in the films, is currently admitted for various problems. You implanted an ICD on this patient.
Right, sir.
In 2015 in care. Okay.
Yes, sir.
At that time, his LVOT gradient was 120. And he had 2 syncopes before that. So for last 7 years plus, he has been doing very fine. No syncopes and almost 0 symptoms. And recently he had an atrial fibrillation, and for that he was admitted. Then he had sepsis and other problems. He is just now coming out of it. He had acute kidney injury with zero output. Morning, I had a good news from my resident that he passed 800 cc of urine. That was the best news we had in the last few days about this patient. Now, what was very striking to me was what was grade 4 plus murmur in this patient when we put in ICD. Now, last 10 days or 12 days, I've been examining him every day. There is no murmur. He is out of north pace, is not on north pace, is not on beta blocker for the last 2 weeks because of his shock related to sepsis. But now his pressures are okay following vasopressors, now without vasopressors, and no murmur. So my residents keep asking me, you have recorded a grade 4 murmur, and now for the last many days there is no murmur at all. What is the explanation? I have an explanation, which I have read about it long back. The thing is, when the hypertrophy extends the posterobasal muscle of the left ventricle, the SAM disappears. So the SAM disappears, the gradient also disappears. That is one explanation that was given. That is the hypertrophy which is extending from septum to posterobasal wall of the left ventricle. Second explanation is if there is a lot of fibrosis around the myocardium where the prognosis is worsening and the fibrosis is extending, then again the SAM may disappear. So no murmur and no gradient. These are the two explanations which people have been writing for quite some time. But this is probably one of the very few situations where I have seen murmur has totally disappeared on its own for whatever reason. You have any comment to make on this particular patient, Narasimhan? Probably one of these days I will send him over after discharge to you.
Right. We have about 3 or 4 patients now that you are saying it reminds. One is a son of a cardiac surgeon, had a severe gradient, and with the onset of atrial fibrillation 5 years later, the murmur is gone and outflow gradient is gone. The third one is a dentist. I think in the natural history of the disease, when the septum becomes more and more hypocontractile and fibrosed, they tend to develop higher LA pressure, and uniformly all of them have developed atrial fibrillation. Now their natural history is punctuated more by atrial fibrillation than by outflow obstruction.
Actually, contractility is very important for the gradient. So if that goes down slightly, the gradient would disappear.
Narasimhan, would you like to summarize the whole thing and then close the session?
Right. Thank you, Malav and Muthaiya, for joining us and presenting this nice case on hypertrophic cardiomyopathy. I would like to thank Dr. Ajay Bahal, Dr. Krishnam Raju, and Dr. Dayasagar Rao for walking us through this important case, which illustrates several important points in the evaluation of hypertrophic cardiomyopathy. When to intervene, number one, how to manage medically the outflow obstruction, and when it becomes refractory, when to consider either a medical or surgical intervention. These things were highlighted very well in the present case presentation. And the importance of imaging to decide whether the MR is going to be a consequence of obstruction and therefore relief of obstruction may relieve the MR versus intervention for MR was well illustrated in the case. Again, we saw that the presence of significant fibrosis predicts the risk of BT and VF, and this may not be completely eliminated by relief of obstruction. Despite obstruction being relieved by surgery, this patient had an aborted sudden death and was resuscitated due to documented VT and VF, and was adequately managed thereafter with an implantable defibrillator. I think there are several learning points in this case, and I would like to thank all the participants for the wonderful contribution. I'd like to close the session.
Thank you.
Thank you, one and all. I think